Thank you, Dr. Scanavaca. Thanks again to Luis and the team for having us. It's a good start to the morning, a nice termination of VT. I was asked to talk about two different topics today. The first one was epi-VT ablation, how to deliver RF in the pericardial space. And I think in the bigger picture, if you're going to be a VT ablator or an epicardial VT ablator, you have to be willing to fail. And I think a number of our panelists can attest to the trials and tribulations of VT ablation. And so I'm going to show a couple different examples from cases that I did in the week prior to coming here, actually. One which was a success and one of which was a failure, and what we can learn from that. This first case is the positive one. It's a 54-year-old gentleman, incessant VT, transferred from an outside hospital on lidocaine. Nothing else controlled it. And when he, luckily enough for us, when we stopped the lidocaine just prior to the ablation, he would have PVCs and short runs of non-sustained VT that matched his clinical sustained VT. This case is actually a non-structural VT case, at least by any kind of measure that we have. His echo was normal, and his MRI was negative for any delayed enhancement. We looked at the PVC morphology, and certainly there maybe were some clues of where we would end up, but given that we were billing him as an idiopathic, we went first with an endocardial approach. We got this sort of diffuse area. You see the RV and LV maps next to each other. Mapped the LV endocardially, and we were getting kind of divergent signals, but all kind of 0 to maybe -10 in terms of the PVC activation in the more apical aspect of the inferior wall. At that point, we decided it had been a long procedure, that we would regroup, and he had not been consented for epicardial ablation. We tried to go deep into the MCV to try to get a sense if this could indeed be idiopathic within the coronary venous system, though on initial inspection, it was a little more apical than we might have expected. It would have had been very distal in the coronary venous system. So a few days later, we brought him back. For our training, mostly for our fellows, I recently have been doing RV grams with, just to give them a sense of where we're headed with our pericardial access. I think it's instructive from a learning perspective, so they can kind of understand how we're getting access. And also just gives us a better understanding of the overall anatomy. We use the standard technique. We generally go with a more posterior approach. I don't think there's a right or a wrong way to do that. That's how I think Dr. Shivkumar learned, and in essence how he taught all of us. And we still do use contrast. We do pericardiograms. It's interesting points that have been brought up about adhesions and contrast. We do drain it, flush it thoroughly at the end of the case, but we like to see in the beginning of the case that we have nice free flow of the contrast, that we're not going to be up against a lot of adhesions, and also just verifying our access is safe. We tend to map with a closely spaced duodec, both endocardially and epicardially, especially with the St. Jude system. This is the duodec in the inferior epicardial space. You see that we're relatively early to this PVC, and then with further mapping, we're a little bit earlier than we were before. We see this divergence of the polarity in the distal duodec, and I'll show you where that is here. So we've come all the way around the heart. We're on the inferior wall. We've shot the coronaries in a number of different views to ensure that we're far away from the coronary venous system. In the REO view you see here, we're more on the apical aspect of the inferior wall. And based on in the LEO, you can see that our earliest sites were in the distal duodex, so we're more on the LV side. We then looked in the RCA as well, and saw that in both views that we're far away from anything in the left coronary system, and looking at the RCA, we're more apical and slightly more leftward than any major vessel. So again, we thought we were far enough away to deliver energy in this region. We did get some levophase and direct coronary and venous injection, and you could see that the MCV was more rightward of where we were. We didn't see it fill distally. It is possible that we were near a branch of the MCV, but certainly not on top of it.
Why you didn't use electronic mapping?
Oh, we did. I'll show you the map. Yeah. I just wanted to show you the general anatomy here. So this was the signal in that region, and I'll show you the map as well. We have this nice, looks like like we're ablating a pathway here. Excellent signal. Just we replace. Sometimes we'll do double epicardial access, and we'll keep the duodec in place, and then because it's such a nice signal, we don't want to lose it. What I found with that is that putting 2 8 French sheaths tends to tent it open, and then you get a lot of air introduced, and then we have sometimes some impedance issues and things. So in this case, because it was such a nice smooth entry to that point, we just pulled, and I had this sheath all the way around. We basically just pulled out the duodec and put the ablation catheter in that spot. Let me get to the map. So here's the map showing a nice, spot of early activation there where that ablation catheter was. Appears to be focal in origin. One lesion with thermocool terminated any of the PVCs. And we did an induction just because he had sustained VT before, and we weren't mapping sustained VT, and there was no inducibility with triples. And again, so these are the good cases. Unfortunately, they're not all good cases. This was from a couple days before I left. This was a gentleman who was 62. He has a non-ischemic cardiomyopathy, thought to be PVC-induced, although on MRI he had a relatively small area of transmural scar on the lateral wall, but his myopathy was out of proportion, and he had a very high burden of PVCs, and it was thought that maybe the PVCs were contributing to his myopathy. And he had had an endocardial ablation attempt by a reputable EP who had no success, and so he was sent to us for epicardial mapping. When we talk about EKG criteria for epicardial origin, you certainly see this kind of pseudo-delta wave here, and if you believe that data, then certainly you'd say, well, this certainly could be epicardial in origin. And so we were using that pseudo-delta wave as our earliest activation for mapping. Again, we went with our standard technique for access. This is the area fluoroscopically where we had the earliest signals, kind of on the high lateral wall. In this case, we ended up somewhat unintentionally with a more anterior stick. This is where the wire went, and so we came around the anterior wall and up and over. And we had, this is where we were with looking at the left coronary system. You can see, we thought we were relatively safe. We always keep, you can see an extra wire in there. We always double wire the pericardium in case we lose access. We come back for something more inferior. Yeah. Yes. If we're going to burn epicardially, yeah. Unless we know something specific, like they had, their certain system was out and we knew there was no real risk. I would say maybe in a rare situation with an incessant VT where I'm willing to take the risk, probably regardless of where their coronary is. I've had 1 or 2 of those where we're willing to take that risk, but we shoot the coronaries basically in every case. If it's a cabbage case, then I'll have the interventional guys do it. If it's a non, then we'll just do it. So this was the signal. We got reasonable signal, 20, 25-ish early in that region. It was the best signal we could have. Pace maps in that area were excellent. So we decided that we'd give this a shot. And after that last case where everything went so perfectly, I said, oh, this is going to be great. It's going to go right away. And we blasted the you-know-what out of this area. And the longest lesion I've ever put was in this case. Shiv and I sat there and said, how long can we actually burn in one area? We put a 6-minute lesion at 50 watts. After doing single-minute, 2-minute lesions, and we would suppress at 30 seconds, 15 to 30 seconds, every time would suppress. But we can never get rid of it. So the question is why? And when you're burning in the epicardial space, you got to wonder, when you're unsuccessful, why are you unsuccessful? Well, there can be obviously a number of reasons. One, if you're dealing with a thick region of tissue anywhere near the base of the heart, the summit of the heart, if you don't have a purely epicardial focus or circuit, and this is more of a mid-myocardial issue, you may not be able to deliver enough of a lesion to get deep enough. As we know, we have certain limitations of technology. Second possibility is that there's epicardial fat there, and the combination of a deeper focus and epicardial fat is really limiting your ability to deliver a lesion. This is actually path from one of my patients who does not have a focal tachycardia. He had some of the worst VT substrate I've ever seen and had numerous procedures. Ultimately, down the road, went to transplant. And this was you can see all the fibrosis. There's no chance you were going to cure this guy of VT. I mean, his whole heart was this kind of microfibrosis. But you do see the ablation lesions that we delivered, and this is an epicardial lesion. You see the epicardial fat, and a very nice lesion epicardially that we delivered when we did an open surgical approach. But if you imagine that his PVC, if it was this patient, was coming from here, you can only get so deep, and you're limited both by fat and by the depth of that origin. Ultimately, how we deliver RF in the pericardium abides by the same laws that endocardial ablation does. We're still driven by Ohm's law. We still, are delivering the same type of energy. And predictors of tissue injury are the power you deliver, the achieved temperature, the duration of delivery. Although there are some limitations, obviously we see it kind of peak at about 1 or 2 minutes. The convective cooling is more of an issue. On the endocardium, we do use irrigation epicardially, but it's not quite the same thing. And then looking for impedance drops. And this was just from Wong and Wood chapter that one of my partners wrote, looking at evidence of lesion formation. And we still try to abide by those general criteria. And contact is an issue in the pericardium, and it's a little more difficult to determine. In the perfect situation of a truly epicardial focus, the amount of contact, like in that first case I showed, is probably not relevant. But when you're dealing with a deeper source, it's often very difficult to tell which direction your catheter is pointing. Are you pointing into the tissue itself, or are you pointing away from it? And that can really have an effect on the lesions to deliver. But when you're deciding to deliver lesions in the pericardium, the first question is, are you in the right place? If you're looking for substrates, are you really seeing scar, or are you seeing fat, or some combination of those two? And our group looked at that years ago, and ultimately it comes down to the fractionation. You can look at how fractionated the signal is and how prolonged the signal is. And true scar tends to be more fractured and more prolonged, whereas fat tends to be, perhaps more far field looking. But giving that a specific cutoff that you can use clinically is very difficult. That's nice scientifically, but it's often very difficult to differentiate those things acutely in a specific case. And then once you decide where you are, the question is, are you using the right equipment? So Dr. Davila, has done a lot of work on this in this regard in terms of when we moved from non-irrigated to irrigated catheters. And certainly irrigated catheters deliver more effective lesions. When there's epicardial fat, though, those lesions are unfortunately smaller. And this was a nice table from that initial paper showing when you're delivering a lesion in normal tissue versus infarcted tissue versus tissue with fat over it, and the depth of those lesions and how that's affected by fat. So it's not that you can't deliver lesions when there's fat, but it certainly attenuates those lesions. And if you're dealing with a deeper focus or circuit, the fat epicardially can be problematic. And this is just, I put through this image from that paper in because it just shows you that basal layer of fat that also runs along the main coronary arteries, and how difficult and frustrating that can be when you're trying to deliver epicardially. So once you decide where you are, that you're delivering with irrigation, the question is, how can you optimize that lesion delivery? And this was a more recent paper by Dr. Davila's group, and I think was a reviewer on this paper, and it just came out in Heart Rhythm. And basically the premise of this was, well, if you decrease the irrigation from the catheter, the flow, does that help deliver deeper lesions? And how are lesions affected by the amount of pericardial fluid? the ultimate take-home point was that getting rid of draining the pericardial fluid is key. And I think we often forget to do that, is the fluid builds up as we're mapping and ablating, and before you know it, there's a lot of fluid in the pericardium, and you're burning, and you're wondering, why are the signals not changing? Why am I not having an effect? And the key is between lesions, you need to make sure to really pull all the pericardial fluid out. They also looked at how much flow to use, and there was really not a huge difference in terms of the flow, but the concept might be that if you're having trouble with the higher flow rates, you could consider decreasing the flow from the catheter, which is what they did in this study. The next question is, how is contact force utilized in the pericardium? And we haven't done a ton of contact force epicardially. This paper looked at contact force and basically said that the more contact force you get, the more you can get through fatty tissue, which makes sense. It's relatively intuitive. But again, when you're getting contact by any parameter that a catheter can give you, the question is, what are you making contact with? And are you truly contacting the myocardium? And what this paper by the Bordeaux group said was basically that at really high contact levels, you may just be pushing away from the myocardium, was my interpretation of it, that it's not really, it's not the appropriate orientation when you have really high contact force within the pericardium. Diego brought this up, as well, and so it kind of brings back to that second case: is what do you do when you're limited either by technology or pericardial fat to deliver the lesions you need? In my case, you could argue that you should go endocardially and maybe do longer lesions endocardially or directly across from the best sites. Unfortunately, in that case, the epicardial stick was clean. But when we started burning with those longer lesions, we started to see some venous bleeding. I suspect that we kind of nicked one of the branches of the coronary venous system. With negative pressure at the end of the case, it resolved. However, I didn't feel comfortable heparinizing for an endocardial procedure at that time. So we've debated bringing him back for limited surgical access to kind of remove some of that fat and potentially ablate surgically, and that's being planned. But the Usha Tedro wrote this nice paper that he mentioned, kind of looking at all the options that are available when standard approaches fail. And they've obviously published a lot on alcohol ablation, but surgical access is also an option, which is kind of at the end of their algorithms here when all of their options fail, and that's where we're headed with that case. We obviously need new technology. Whether HIFU or some other technology will be the answer to deliver more effective lesions, I don't know. But it is important for us to be able to deliver lesions to affect mid-myocardial circuits. How that will be done is yet to be determined. Ultimately, in summary, when you're delivering lesions on epicardium, you do want to use irrigated RF. We tend to use higher power because we're not so much worried about steam pops and things in the epicardium. You do monitor the same criteria: impedance drops, EGM reductions, loss of LPs, or you can look at electrical loss of capture. You do want to make sure to drain the pericardium regularly between lesions. You could consider decreasing your flow rate, and longer lesions are certainly acceptable, with certainly less risk, I think, than in the endocardium. And if all those things fail, you may consider some of these other options like surgical access. Okay. You want me to stop in between, or do you think?
For instance, in Brazil, I don't know, in the rest of Latin America, most of our epicardial procedures are in Chagas heart disease patients who are very poor, so they do not have access to high technology hospitals. So basically in Brazil, what we are doing, we still use 8mm catheters for this kind of procedure, and most of the times it works well. But obviously, if we could use irrigated catheters would be better. Do you have any experience with the closed loop, the closed irrigation systems?
How much watts do you use with the 8 millimeter tip? 70.
70.
You?
50. We have used the closed loop irrigation in the past. Why we moved away from it and back to thermical, or, yeah, it's just sort of what we're used to. This is totally unrelated. I just wanted to show this quick slide because this is related to the case Luis was showing earlier, which is, you have a scar, you have no late potentials. This is a paper that is actually just got accepted that Rod and I did with Shiv and Dr. Josephson, looking at wavefronts of activation when you have difficulty finding substrates to ablate. And so that should be in publication soon. But the interesting point is that these are the same exact points on the same exact patient. And all we did was change the wavefront of activation by either pasting the LV lead or using sinus versus the RV lead. And in a number of cases, you can see that in the exact same point, you'll see scar and late potentials where you saw completely normal voltage and no late potentials with the other wavefront. So it shows you the complexity of scars and how wavefronts of activation can affect the local scar. And we have a number of these cases where you see the late potentials in one and not in the other, and even a few where we terminated the VT from normal tissue. So it's something to consider when you have what you think is going to be a failed procedure because of a relatively small patchy scar with no late potentials, and you don't have a substrate to ablate. That substrate may be different if you look at it from a different activation wavefront. That's obviously not easy to do when you don't have a BIV. But if you do have patients with BIVs, or you can pace with a catheter in the LV, you can do a similar.
But do you use this approach routinely or only when you don't find a good scar in the endocardium?
Yeah, no, I mean, we did it in this was a research project, but it doesn't seem to make sense in large, dense scars, is what our experience was. If you have a large, dense scar, it tends to be the same no matter which way you look at it. In the smaller, more patchy scars is where you see changes based on the wavefront. So we think it's useful for, those non-ischemics where you don't find any substrate and you're about to just throw in the towel and say, there's nothing I can do for this patient. It may be worth remapping with a different wavefront because maybe you'll find interesting signals that at least may or not help the patient, but clinically, but it may be worth, before you get out. In today's case, just brought that up, reminded me of this. Okay, the second talk Luis asked me to give was a collaboration that our two centers had together that we presented at Heart Rhythm and now is in Heart Rhythm a couple months ago. And that's looking at bilateral cardiac sympathetic denervation for intractable arrhythmias and Chagas disease. And as Luis mentioned, we have a Center of Excellence for Chagas disease in Los Angeles, which is the only one in the States. And so we have a large number of Chagas patients. And our experience with ablation of Chagas is nothing like our colleagues here, but it's been relatively limited. But unfortunately, in the limited number we've had, our success rates haven't been great. And so we have a few that have failed, and they ultimately went to stelectomy at our institution. And Luis has incorporated that option in either failed procedures or for patients that have not been candidates for various reasons for ablation. And it's an idea that we wanted to share with you, and I'll show you that data. So obviously, in the perfect situation, we can ablate VT, we can have all these amazing signals, we can have late potentials and mid-diastolic potentials like Furman showed us, and we terminate VT and we give high fives and we're very happy. But that's not always the case. And when endocardial ablation fails or there's an epicardial substrate, we can do epicardial mapping, which we've been talking extensively about today. And we can do high-density epicardial and endocardial mapping. And hopefully, again, epicardial mapping may be the answer. But ablation isn't perfect. And despite our best efforts, especially in the non-ischemic population, success rates are somewhere around 50%. And patients often require multiple procedures. So the question is, when ablation fails, and if it fails, what are the options that we have as an alternative. And it may not just be about failure, it may be about substrates that simply, again, our technology cannot adequately address. LV Summit VTs are very difficult to address because of how thick that tissue is. Intraseptal VTs, we've done wire mapping and all kinds of stuff, but again, you're dealing with regions that are difficult to get to. So what happens when the technology we have fails, or we simply are unable to control the arrhythmias for various reasons? Our group has been very interested in the autonomic interactions with arrhythmias and how we can intervene to help control arrhythmias from an autonomic perspective. And obviously that interplay of neurocardiology is very complex and still needs a lot of research. But what we do know from the literature is that patients that have long QT with recurrent events, people that have CPVT with recurrent events, benefit from left stellate ganglionectomy. And we, many years ago, translated that into the cardiomyopathy patient population when we had really no other options with patients that had come to our center and had recurrent VT despite our best efforts with ablation. So that's done thoracoscopically. Our thoracic surgeons identify the lower part of the left, the cervical ganglia and the T2 to T4 ganglia, and they remove them. And we initially started with left stellate ganglionectomy because that's what was in the literature. And we had some success, but ultimately some recurrences, and went to more of a bilateral approach, which has really been our approach since that time. And so we initially published our original experience in Circulation, and then this was Dr. Visegi's intermediate follow-up and long-term follow-up paper that was in Heart Rhythm in 2014. On 41 of our patients, the number is about double that now. We're somewhere, I think, in the 80s at this point in terms of patients that have undergone this procedure. When you look at the patient characteristics of that patient population, it's relatively heterogeneous. Predominantly non-ischemics. There are a couple of stochastic patients in there, but a wide variety of patients were included. And if you look at that data, the success rate in terms of freedom from VT at 1 year was somewhere on the order of about 50%. And one could argue, well, 50% isn't a great success rate. But I would argue that in a patient population that's failed multiple ablations, 50% at 1 year is not half bad. And so we took that data and said, well, are there any subpopulations that maybe would benefit even more relative to the group as a whole with bilateral stelectomy? And I always had this feeling that perhaps, I mean, there's a wealth of literature in the Chagas literature about autonomic dysregulation and ventricular arrhythmias, and we thought, well, maybe the Chagas patients would benefit even an incremental degree relative to the other patients, if indeed this literature on autonomic dysregulation is indeed true. And like I said, it's not just certainly it's a huge issue in South America and Central America and Mexico, but it's also because of a large number of immigrant patients in the United States. It's a growing issue, especially in regions such as Los Angeles and Texas, where they have a large immigrant population. And like I said, our experience has been success rates for our limited number of patients that we've done hasn't been great. And they have complex, Chagas patients have complex scars, often, like as we discussed, epicardial or some mid-myocardial scars. And we've been looking at our patient population with a recent MRI paper. And in some instances, they can't have an ablation. They have a relatively recent thrombus. Maybe they have an apical aneurysm. So the question then again becomes, how can we help these patients given the treatment options? So basically in this, we look right back at cases from our institution and from the center here for patients that have Chagas disease that underwent bilateral stelectomy. At that time, there had been about 75 total patients between the two centers that had undergone this procedure. And of those, all the patients that we looked at had monomorphic VT. The median follow-up for the Chagas group was 7 months, although a wide variety. One had died not too long after from unrelated causes, and another one had been followed all the way out to 46 months. They'd all undergone either unsuccessful catheter ablation or, for various reasons, were not candidates for ablation. The median number of shocks 1 month prior to the bilateral stelectomy was 4, but up to 30 in one patient, and decreased to somewhere between 0 and 2 in the available follow-up. When you included anti-tachycardia pacing, which was one of the questions that the reviewers had when we first submitted this, we originally just included shocks because that's what we had presented in our initial papers. But then when you include ATPs, again, the numbers are still, I think, impressive with dropping to 0 to 3, and I'll show you those graphs. So this is the patient characteristics. Obviously, three of them are from the center. They're from Colombia. Of our patients, 3 out of the 5 were from Mexico. Excuse me, 3 out of the 4, and 1 was from El Salvador. Our El Salvadorian population has a very high incidence of Chagas in the immigrant population. EFs were all over the map. Virtually all of them presented with electrical storm, one with what would be classified as refractory VT. They'd all basically been on amiodarone and beta blockers or other antiarrhythmics. And if you look at the post-surgical intervention antiarrhythmics, they were virtually unchanged. There were some minor tweaks either up or down in beta blockers, but very similar to pre-surgical. And this is the graph of number for ICD shocks only. One patient in green there actually had a failed ablation, had an EF of 10%, had a failed ablation with actually complicated by perforation, and therefore couldn't have a successful ablation. Underwent stelectomy, but unfortunately because of how sick he was and his low flow state, ended up with numerous other medical issues that ultimately led to his death that were not arrhythmia related, but during sepsis and other issues in the first month post, he did have 2 shocks. One patient at 4 months from this center had recurrence, but interestingly, that patient had a very fast VT before stelectomy, was not a candidate because of a thrombus, so did not have ablation, and when he came back with VT, he had a very slow VT. And we've seen that in a number of our patients where they have very fast, possibly even polymorphic VT, and after stelectomy, they come back, if they come back with VT, they come back with slower monomorphic VTs, which potentially are more mappable and easy to ablate. This was the data when you include ATPs. Similar, one of my patients had a couple of ATPs at 4 months, but has been free of arrhythmias over the last couple of years. So this is obviously a very small series with promising early results and needs more data. We know that VT substrates are complex, and sometimes we can't modify them at the myocardial level. Cardiac sympathetic denervation shows promise as a therapeutic approach for managing ventricular arrhythmias for a variety of substrates. And if the idea of autonomic dysregulation is more prominent in Chagas disease, then perhaps bilateral stelectomy. Okay, yeah. Yeah, I'm done, so it's great, yeah. Perfect. Bilateral stelectomy may be a consideration in this patient population, either for patients that have failed ablation or are not candidates for ablation, or you may be at a center where epicardial ablation is not an option, but you do have a good thoracic surgeon that can perform these procedures, and in those situations, maybe it's an option for patients that have limited options to go elsewhere. And that's it. Thank you.
Yes, just one quick question for the 3 of you. Do you consider an apical aneurysm a contraindication for epicardial access?
Apical aneurysm is very common in patients with Chagas disease, so it's not a...
Do you have any recommendation to avoid the aneurysm during the puncture, or
No, because in general, when we do the puncture, it's never towards to the left. So we've never seen any problem with the aneurysm.
I would say in some ways it makes me more likely to do an epicardial access because I'd be worried about doing endocardial and then perforating and then having to get epicardial access emergently when I perforated. So I'd rather have epicardial access at the first. And when you stick, I always try to aim for the kind of the mid, when I line it up in RAO, sort of the mid RV region. So if you're there, you shouldn't be anywhere near an apical aneurysm.
In our population with Chagas, we have like a 45 to 50% of arrhythmic storm in patients with ICD, especially in patients with the slow VTs that are paced, turn into VF and shock and again and again and again. In your patients with the stelectomy, have you been shown that this might reduce also the arrhythmic storm episodes?
Which is low VTs.
I'm not sure. Well, I mean, yeah.
Reduce arrhythmic storm in patients?
Well, I mean, all of these patients presented with electrical storm, and none of them have, except for the one patient that had never been ablated, came back with sustained VT that wasn't getting shocked, but was tolerated. None of, there's been no, outside of that 4-month period, there's been no shocks, period. And we have one patient that's been out 4 years, another one that's been out a couple years, with virtually no change in their antiarrhythmic regimen. So these are all patients that were storming repeatedly. You could argue, and one of the reviewers made this point as well, how do you know that you're not missing slow VT that's outside of the device detection? And we can't rule that out completely. There was no changes in our device settings pre and post for any of the patients, but we didn't, because this wasn't a prospective study, we didn't empirically put a monitor zone at, say, 110 beats per minute to try to catch those slow VTs. But at least clinically, with clinical follow-up and symptoms, we haven't had any evidence of that.
Horner syndrome after stelectomy?
We haven't had much Horner's. We've had some patients that get a very weird neuropathic pain that tends to go away in about 2 months. But one of our Chagas patients had severe skin pain that lasted about 2 months. It was very difficult to treat. They often get this kind of sweating issues that, again, often improve, but that are really kind of bothersome. They're not dangerous, but where their sweating patterns change dramatically. In some ways, we like that because we know we did something. Because in the beginning, we weren't sure what people were. It's not that easy to see the stellate and know that you got it out. And so, you could take out some tissue and not have taken out the right thing. And so when we see some effect, we know at least that the right tissue was taken out. Yeah. We've tried that. Our pain management guys have tried to do that in a couple of our sick patients that maybe the surgeons weren't excited to take and they wanted to prove that it would benefit. But they do that largely fluoroscopically and anatomically, and they go to like the rib and they put in a little microcatheter. I don't think they consistently get to where they're supposed to get it. It's not, they're not good enough at doing that to get to the right spot to really prove me right or wrong in terms of whether it's going to work. But we have tried that in a number of cases.
La pregunta iba dirigida al tema de una terapia combinada de ablación como un primer episodio en pacientes con cardiopatía chagásica asociada a simpatectomía bilateral. Una ablación puede dejar no inducible en la cicatriz en Chagas, pero sabemos que esto es una enfermedad progresiva. Entonces, ¿qué opina de esa terapia combinada desde un primer procedimiento?
Combined therapy with ablation and stelectomy in order to prevent recurrency.
It's a good question. We've handled this in a number of ways. A number of our non-ischemics that come in, especially those with irregular, very rapid VTs that we suspect will not be mappable, we will often empirically have our stelectomy team, so to speak, see them as they come into the hospital, knowing that there was a high likelihood that we'll take them to stelectomy during the same admission. It's not a protocol per se, but we'll often have that in place when we think that there's no MRI scar. We may study them, but there may be nothing to map and ablate, and so we'll kind of plan for that empirically. but we haven't been consistently doing it as a combination